Hello, my name is Tom Buchholz, and I have the pleasure today to moderate today's tumor board discussion. And first off, I'd like to introduce a truly outstanding multidisciplinary panel who's going to be talking over our cases today. First, I'd like to introduce Dr. Frank Vicini. Frank's representing radiation oncology. Dr. Vicini, can you tell us a little bit about yourself?
Sure. I'm based in Michigan. I'm fellowship trained in breast cancer radiation therapy, been involved in clinical trials through the National Cancer Institute and even internationally. So my focus is on early stage breast cancer and reducing long-term morbidities.
Thank you, Dr. Vicini. For our surgeon today, we have another national thought leader in breast cancer, Dr. Terry Mamounis. Dr. Mamounis, would you care to introduce yourself, please?
Yes, thanks, Tom. Terry Mamounis, I'm a breast surgical oncologist based in Orlando, Florida. Direct the comprehensive breast program at the Orlando Health UF Health Cancer Center. I also work with the NSABP and now NRG Oncology as the chair of the breast cancer committee, and have been in the business of designing and conducting clinical trials for almost 30 years.
Thank you very much, Terry. And representing medical oncology, we have Dr. Ruth O'Regan. Ruth, would you mind introducing yourself, please?
Yeah, hi, I'm Ruth O'Regan. I'm a breast medical oncologist from the University of Wisconsin, also Deputy Cancer Center Director of the Carbone Cancer Center. And my area of interest really is in clinical trials in resistant breast cancers, including triple negative breast cancer. So I'm very happy to be here and look forward to discussing these cases.
Thank you, Ruth. And finally, the fourth panel member representing diagnostic imaging and radiology is Rennie Butler. Dr. Butler, would you introduce yourself, please?
Hi, and thank you. I'm delighted to be here as well. I am a diagnostic radiologist with a specialty in breast imaging at the Yale New Haven Hospital and on the medical faculty of Yale School of Medicine. I'm also participating in clinical trials. My main area of interest is digital breast tomosynthesis, which is a relatively new technology that has made mammography a better test, as well as breast MRI. And I look forward to discussing these cases with the panelists and learning from each other.
Thank you, Dr. Butler. Dr. O'Regan is going to be presenting this case.
Yeah. So this is the case of a 66-year-old lady who was found. I'm not exact, can't quite recall why she was having the CT of her chest done, but anyway, on the CT of her chest, she was found incidentally to have a right breast mass. She's healthy without other medical issues. Obviously, is postmenopausal, never smoked. Her mother had breast cancer, and she did have full paleogenetic testing that was negative. So her imaging, she had a mammogram, a diagnostic mammogram, an ultrasound done, which showed a fairly large 44 millimeter mass, very posterior in the right breast. She actually did not have an MRI prior to surgery. And she had a breast biopsy performed, which showed what was felt to be a malignant spindle cell neoplasm. So because it was thought maybe this was a phylloides cancer, she didn't have any further breast imaging. She went straight to surgery.
So can you tell us a little bit about this entity called metaplastic carcinoma of the breast? It's
Sure. So that was actually actually maybe just go ahead, because she went and had a right partial mastectomy, and as you can see, had a pretty large cancer. Did not have lymph nodes taken out because they thought it was phylloides at the time point, and lo and behold, it came back as a metaplastic cancer, which was high grade and triple negative, which is pretty typical for these type of cancers. So basically, metaplastic cancers are almost always triple negative cancers. They're fairly resistant to systemic therapy and generally have a fairly poor outcome. They do have activation of the PI3 kinase pathway. So certainly in the metastatic setting, there are some very interesting trials going on, but it's just really a specific type of triple negative breast cancer that unfortunately tends to be quite resistant to chemotherapy and generally has a poorer outcome than other triple negative breast cancers.
So, Dr. Mamounis, This was approached first as a phylloides malignancy. Given the findings of a metaplastic carcinoma, let's assume that the margins are negative on the partial mastectomy. Do you feel as if going back and doing a sentinel lymph node procedure would be indicated? Do you feel as if metaplastic carcinoma should be treated with mastectomy, or how would you approach the surgical management of this case?
So we don't necessarily differentiate in terms of the primary breast surgery between metaplastic and other cancers, as long as the patient is a good candidate for breast conservation and we have good negative margins. I think we can go with that. We do have to check lymph nodes. We usually would do a sentinel lymph node biopsy, and I would propose that for that patient. Metaplastic carcinomas tend to be less involving the axillary nodes in a lesser rate, if you like, because sometimes they act more like a sarcoma. But still, the standard of care is to perform a sentinel lymph node biopsy in this case. So I would definitely do that for this patient.
Dr. Piccini, Dr. O'Regan mentioned that this histology tends to be a little bit resistant to conventional chemotherapies. What are your thoughts about this histology and use of radiation? I assume that as breast conservation, you would be treating the breast. Do you use conventional fractionation schedules as opposed to hypofractionation schedules? Do you consider additional fields to treat lymphatics in this setting? Or if her lymph nodes were negative, would you just be treating the breast chest wall in itself? Or how would you approach this case?
Sure. Well, typically, we've had quite a few of these metaplastics through the years. We treated them very similar to a standard breast cancer in terms of giving whole breast irradiation to around 50 gray, meaning 5 weeks of treatment. But we tend to boost these to a little bit higher dose because of the metaplastic nature. In other words, typically we'll go to 60 gray, but some of these cases we take them up to 63, 64 gray. Depending upon whether or not Dr. Mamounis has done a lymph node dissection, will dictate whether or not we consider regional nodal radiation therapy in these patients, obviously. If he does do lymph node dissection, sentinel lymph node biopsy, obviously we wouldn't treat the nodes. The cases that I've had through the years have pretty much routinely not had positive lymph nodes, so it's made it easier. I've not had a situation yet where it's been in the nodes, but certainly one would have to consider that. Would it, after a mastectomy, that's the real question. Had this patient been treated with a mastectomy, would we treat with post-mastectomy radiation therapy? She does have almost 5 centimeter tumor. It is much more aggressive. I think in that situation, I might consider post-mastectomy radiation therapy. But in this case, we would treat it with pretty much standard breast conservation techniques, but a higher dose to the lumpectomy cavity, taking into consideration the more aggressive tumor.
The other issue that you mentioned the dose and a lower total dose. So you're using a fractionation that extends the treatments out to 6 weeks or greater, which is very appropriate. Do you do that for all triple negative disease or just the metaplastic? We've heard a lot of this so-called hypofractionation as a component of breast conservation.
Yeah, that's a great question. Obviously, the trend over the last 5 years or so has been to switch from the standard 6 weeks of radiation therapy to hypofractionated radiation therapy delivered in only 3 weeks. And that's based upon a couple of different trials that have supported that fractionation schedule. The problem is they did not include a lot of patients with triple negative breast cancer or some of the more aggressive cancers. So right or wrong, we've tended to use the traditional fractionation schemes in these more aggressive cancers, in other words, 6 weeks of radiation therapy, and not tried to use hypofractionation simply to finish their treatment quicker.
And Dr. O'Regan, we'll give you the last word in terms of choice of adjuvant systemic treatments now. What would be your recommendation if her lymph nodes, say, were negative and she has this aggressive histology?
Well, in truth, the recommendation I think would be the same whether she had lymph nodes involved or not. So I would give her an anthracycline taxane based regimen. So in this case, I actually saw her. She's planned to have a sentinel lymph node, but we actually decided to give the chemotherapy before she had the lymph node done. So she's just completed weekly Taxol and she's going to start adriamycin cytoxin. So a pretty standard treatment for triple negative breast cancer. I think one point to mention here is, of course, if we'd known that she'd metaplastic cancer, given the size of this cancer, this is something we probably would have thought about a preoperative approach for with systemic therapy, with systemic chemotherapy, but obviously we didn't know that at the time of her diagnosis.
Thank you very much. So are you treating with a dose dense schedule then?
I typically, for triple negatives, I'll typically give the adriamycin cytoxin dose dense and then weekly paclitaxel. With COVID, I've been starting more with paclitaxel just because I think the weekly schedule causes less immunosuppression, and then give them the adriamycin cytoxin afterwards. We'll say that's probably a little futile, given that I think that's what we thought. We thought we were going to get a big surge, but obviously it's an ongoing issue, so I don't know that we'll continue doing that.